Hello, everybody. I'm Dr. Mian from McMaster University in Canada, and I'll today briefly summarize for you the abstract that we presented at ASH in New Orleans just last week called Need for a Dynamic Frailty Risk Assessment Among Older Adults with Multiple Myeloma, a Population-Based Cohort Study. As we know, multiple myeloma is a non-curable cancer of older adults. We also know that frailty is increasingly recognized as a high-risk feature that's associated with poor survival and high rates of toxicity. Now, many tools have been developed to measure frailty, but they're often limited because they're only used at the time of diagnosis, and often they only contain variables like age and comorbidities that may be less responsive to short-term change. Therefore, there's really a critical knowledge gap about frailty. And the question really is, does frailty change over time in multiple myeloma? And as you can imagine, that understanding this is quite important because if the frailty improves, one could potentially escalate myeloma therapy. And if the frailty further worsens, then one may have to further de-escalate therapy. So this idea of dynamic frailty may be really important for really personalized treatment for our patients in the future. And to answer this question, we conducted a study where we really wanted to answer three questions. We wanted to know, does frailty change over time in multiple myeloma? We wanted to examine the relationship between frailty and survival at different time points, and also identify factors that may be associated with that frailty worsening over time. To really do this study, we did what we call a population-based cohort study, and we used an administrative database from the United States called the SEER Medicare database. Now, we identified patients with newly diagnosed multiple myeloma who had gotten what we call novel drugs between January 2007 till 2014. And then we went on to create this frailty index and calculated it for each patient, both at the time of diagnosis as well as at each landmark interval. So we recalculated the frailty score at 1 year, 2 year, and 3 year post-diagnosis and categorized patients into the 5 categories that I have outlined for you below. And once we did our study cohort selection, we had a total of 4,617 patients that were included in our study. I have on this screen a couple of the selected patient characteristics from our study. So as mentioned, our total cohort was over 4,000. And among that, 5% were what we call non-frail, whereas up to 16% were severely frail. The median age in our cohort was 75, just over half were male sex. White race was the most common in our cohort, Medicare enrollment in about 23%, and about 27% of the patients had combination therapy with both a proteasome inhibitor and an immunomodulatory drug. And as you can see, some of those proportions were slightly different among the severely frail group, which in general were older and had lower rates of the combination therapy. So I'm really excited to share our results with you. So this highlights what happens to frailty over time. So you can see on the x-axis, we have time. So time of diagnosis, year 1, year 2, and year 3. And in each of the colors, we have the different frailty categories, all the way from non-frail in the green to severely frail in the red. And you can see whereas certain patients remain in the same frailty category going from year 1, year 2 to year 3, a number of patients, in fact, either improve or deteriorate their frailty categorization. And in our study, it was interesting to note that among all patients that we followed for the follow-up period of 3 years, frailty categorization changed in 93% of the patients. It was also interesting to note that it could either improve or deteriorate. Next, we also wanted to look at, how is frailty related to overall survival? So on the right-hand side, I have the Kaplan-Meier curve, which looks at baseline frailty and its impact on overall survival. And as you can see, consistent with previous studies that have been done, if you're non-frail, your survival is better compared to someone that's severely frail. Then we wanted to take a look at, is baseline frailty best for overall survival or a recalculated frailty index? So for this analysis, we created multivariate models and looked at overall survival as an outcome. And as you can see, while baseline frailty at year 1, year 2, and year 3 loses its prognostic ability for overall survival, a recalculated current frailty index, in fact, retains its prognostic ability for that outcome. So this suggests to us that perhaps recalculating a current frailty index at each of those time points at 1, 2, and 3 year may be better predictive for outcomes than just a frailty status that was done right at the time of diagnosis. We then also looked at, well, what factors were associated with a worsening frailty status 1 year following diagnosis? And in this, age, Medicare enrollment, and a combination therapy with both proteasome inhibitor and immunomodulatory agents were associated with worsening frailty status 1 year following diagnosis. So with this, the summary of our study really is that frailty is dynamic. It changes in the majority of patients, and in our study, in over 93% of the patients during the follow-up period. Also, it can go both ways. It can improve or deteriorate. I think we also highlight that you really need to recalculate a frailty score because that's potentially a better predictor of outcomes than a frailty status that was done just at the time of diagnosis. And then we also looked at some factors that were associated with worsening frailty status over time. So in conclusion, the strengths of our study is that this really gets at the concept of dynamic frailty. And I really think we need to start to think about that more, both in clinical practice as well as in clinical trials when we're measuring frailty. Some of the limitations of our study are that, this was a population-based study. So why did the frailty change among patients? I don't know exactly the reasons. Also, we calculated a specific type of frailty tool called the cumulative deficit approach, and how our results would differ if we use more myeloma-specific frailty tools like the IMWG or the revised MCI, we don't quite know yet, but we are conducting future studies to look at that as well. So with this, I hope that you've enjoyed our brief summary of the presentation we did at ASH, and thank you so much.